Hello everyone. Today's topic is biomedical waste management, and this is very important topic related to hospital acquired infection or healthcare associated infection or nosocomial infection. So first we will see what is biomedical waste. So what is BMW? It is the waste that are generated during the laboratory diagnosis, treatment or immunization of human beings or animals, or in research activities pertaining thereto, or in the production of biologicals. So these waste maybe they are generated in the hospital, so they may be syringes, needles, or gloves, masks, vials, or disposable syringes and needles, catheters, and also vials, the empty vials of vaccines. So these are the waste which are generated in the hospital environment. Now, which are the hazards associated with BMW? So the important hazard is as if we will not segregate the things properly, or the waste it is thrown outside without any treatment, or it is thrown in the open space, then it may lead to AIDS, hepatitis, tuberculosis, and also it is responsible for air pollution, and in the hospital environment it is responsible for hospital acquired infections, and if the hospital water or liquid waste it remains untreated, then it leads to various other infections and scavenging by rat pickers and animals. So these are the hazards associated with biomedical waste management. So biomedical waste rule in India formulated this uh, rule in 1998, which had classified the waste into 10 categories and segregated into 5 color-coded containers. So it is there are considerable overlapping between categories, created ambiguity and confusion. New BMW guidelines published in 2016, amendment added in 2018 and 19. So previously it was formulated in 1998 and segregated into 5 color coded containers. But there is overlapping between the categories, and this created ambiguity and the confusion. So new BMW guidelines published in 2016 and the amendment added in 18 and 19. Now, which are the various waste management processes? So what we are doing, first we are segregating the things. Segregation means separating the waste. Second is packing and labeling the waste. Third, storage and transportation. And lastly, disposal of waste. So what is segregation and why segregation is essential? Segregation means separation or isolation of various waste into various bags. So 85% of the waste it is non-infective waste, so it is collected in the black bag, and only 15% is infective. So money required for only 15% of the waste. 85% of the waste it's non-infective, plus only 15% it is infective, so it makes 100% infectious waste. If all these they are combined, then cost incurred will be much more than this only 15% infective. So we have to segregate the 15% of the infective, and we have to dispose it properly, and this 85% it is non-infective, so the money is required is very nominal amount, but for this money required is more, it's for only 15%. But if we will not segregate the things, 85% non-infective, 15% infective, if we will combine both, 100% infectious waste, so it will require more money for treatment. Now waste segregation. According to BMW Rule 2016, segregation should be done by using containers of 4 different colors. Each is designated for segregation of particular waste category. Now, yellow container. So, yellow is used for human anatomical waste, human tissue, placenta, dead fetus, umbilical cord, organs, body part from OT, and amputated limbs. And also animal anatomical waste, animal body parts, organs, tissues from the animal house, and other things are microbiological and other clinical lab waste, lab culture, live vaccines and blood bags. They are discarded in the yellow. Discarded or expired medicines and cytotoxic drugs. They are the dry chemical waste discarded in yellow bin. And discarded linen waste, mattresses, bedding, all used mask, gown, head cap, and soil waste, soil, cotton, pad, dressing materials, and plaster. So second bag is red bag, all plastic and rubber items, IV sets, plastic IV bottles, syringes without needles, needle caps, gloves, plastic apron goggles, blood sets, corrugated drains, Euro bags, all tubings, ET tubes, rice tube and drainage tube, all catheters, urinary suction, cardiac sheath, all these they are kept in the red bag. So the third bag, it's a white bag. All metal sharps, they are kept in the white bag. So all sharp items such as syringes with needles, scalpels, all types of blades, lancet, LP needle, needles from the needle tip cutter, all these are added in the white bag. Now fourth one is the blue bag or blue container. So all glass bottles, solution bottle, syrup bottle, IV bottle, used vials and broken ampules, metallic implant, glass test tube, slides, cover sleeves. All these are kept in the blue bag. And last one is the black bag. All non-infectious general waste, they are kept in the black. So kitchen waste, teacup, food waste, all covers, wrappers, paper, empty boxes and office waste, and also covers of blade and suture materials, they are added in the black bag. So these are the segregation of biomedical waste. So yellow, red, black, blue. We had already seen which things are added in the yellow, which things are added in the red, which are black and the blue, and the puncture proof box. So yellow, we had already seen human anatomical waste and animal anatomical waste. They are kept in the yellow. So it may be tissues, organs, placenta or body parts, and bloodstained cotton, dressing pads, cotton swabs, blood bag, protective wear such as mask, head cap, apron leggings, used HIV kits, expired or discarded medicine, cytotoxic drugs, dry chemical waste, discarded linen mattress, beddings contaminated with blood, lab culture stocks, residual toxins, dishes and devices used for culture. All these are kept in the yellow, and the treatment is by incineration. So second is the red. As we had seen, all the plastics they are added in the red bag. So it is IV sets, plastic IV bottles, syringes without needles, needle cap, Euro bag, gloves, tubings, ET tube, Riles tube, and the drainage tube, all catheters, urinary suction, cardiac sheath. All these are added in the red blood cells and all plastic bottles. So the treatment is done by microwave. Black, all the kitchen waste, all the general waste, they are kept in the black bag and they are thrown in the dump yard. Blue bag, all glass items, penicillin bottle, all glass bottle, solution bottle, syrup bottle, IV bottle, used vials, broken ampules, metallic implant, glass test tubes, slides, cover slips, they are added in the blue. And the puncture-proof box, needles, scalpels, all type of blade, lancet, LP needle, all these are thrown in the puncture-proof box. And these things, they are um, disposed in the sharp pit. Segregation of the waste in the wards. So how to segregate waste in the ward? So it's under supervision by lecturer or associate professor of the department, by sister in charge. So double layered bag is there, and on that biohazard symbol is essential, and for COVID-19 waste. Okay. Ward number, we have to write it, ward number on it, name of the sister in charge, name of the ward boy, and date and time. Disinfection policy, spill management, and equipment care. What will you do if there is spillage of the blood on the floor? What you will do? Spill management. Spillage of the blood, body fluids, and chemicals can occur anytime on the hospital. Risk assessment. We have to see the risk assessment, and we have to prepare always ready with the spill kit, and we should have several standard operating procedures, and the staff from the hospital, they should be trained in management of the spillage. Now, what is spill kit and what it contains? So, what is spill kit? It is a kit used for management of the spillage. So, blood and body fluid spill kit contains PPE, personal protective equipments. So, it includes gloves, apron, mask, shoe cover, eye protector. Second, absorbent material like gauze piece, paper towel. Third, waste collection bags. Fourth, disposable forceps. Fifth, two cardboard pieces. Sixth, bucket and mop. And seventh, signage board for no entry. How to manage? So, the spillage, a spill of the blood from the syringe. So spot spill. So this is a spot spill. When only one or two drops are spilled, it is called spot spill. Management. Select appropriate PPE. Wipe up the spot immediately with a damp cloth, tissue or paper towel. Seek, and next is discard the contaminated material in 1% sodium hypo solution and perform hand hygiene. So what we are doing in the spot spill, it is a very small 1 or 2 drop of spillage. So we have to select the appropriate PPE and wipe out the spot immediately with a damp cloth, tissue or paper towel. Discard the contaminated material in 1% sodium hypo solution and perform hand hygiene. Plan of action for large spillage. So large spill, this includes when there is spillage of large portion of the sample or more than 10 ml of the sample spillage. Management, no entry to signage place. So we have to apply the signage board. Wear PPE. When sharks are involved, they can be picked up by using the forceps and then discarded into appropriate BMW. Spill management. Spill area covered with absorbent material. Then 10% or 1% hypochlorite is flooded over. Spill and absorbent material should be covered. Waiting period for this, for 1% hypochlorite, sodium hypo, waiting period is 15 to 20 minutes to 30 minutes. 10% is 5 minutes. Chlorine granules 5 minutes. After waiting period, the absorbent pad is removed and discarded. Now next is the cloth. Absorbent material should never be turned during disinfection because this will spread contamination. Mop all the floor and worktops by using household phenyl solution. Remove your PPE All contaminated items used in the cleanup should be placed in a biohazard bag for appropriate use and perform hand hygiene. Now next is disinfection of equipment. So in that defibrillator, they are sterilized by soap and detergent, alcohol wipe. USG machine, soap and detergent, alcohol wipe. Laryngoscope handle, alcohol wipe. Laryngoscope blade, 2% glutaraldehyde. Ambu bag, soap and detergent, dry, 2% glutaraldehyde. CO2 probe, alcohol wipe. Now next topic is needle stick injury. So what is needle stick injury? A percutaneous piercing wound typically set by a needle point but possibly by other sharp objects or instruments. So injuries occur when people use, disassemble or dispose of needles. Mainly transmit three major blood-borne viruses: HBV, highest risk of transmission, it's 30%, SCV, it's 3%, and HIV, it's 0.3%. So this is a multiple choice question. So which virus is transmitted? The risk of transmission is highest. So it's HBV, hepatitis B virus, it's 30%. HIV is least, having least risk of transmission, it's 0.3%. Who is at risk? Nursing staff, emergency care provider, labor and delivery room personnel, surgeons and operation theatre staff, laboratory technicians, dentists, health cleaning or mortuary staff, or waste handlers. How do needle stick injury occur? So the needle stick injury occur mainly it's because of the recapping, and other reasons are equipment design, nature of procedure, condition of work, staff experience, and disposal. Now, how to manage it? Post-exposure prophylaxis. So first, these are the various steps how to manage the needle stick injury. So first we have to view first aid. Then second means we have to clean the area with soap and water. Do not squeeze it or do not take the finger in the mouth so to suck it. Second, report to designated nodal center. Third, take first dose of PEP for HIV. Laboratory testing for blood-borne viruses. Next is decision on PEP for HIV and HBV. Sixth, documentation and recording of exposure. Seventh, informed consent and counseling. Eighth, follow-up testing of healthcare workers. And ninth, precautions during follow-up period. First aid. Do's: wash wound with soap and water. If splash, irrigate the site thoroughly. Don't do not panic. Do not place pricked finger in the mouth. Do not squeeze blood from the wound. Do not use antiseptic and detergent. Report. Next is report to designated nodal center. So hospital infection control committee office act as nodal center. Other hospital may designate staff, clinic or casualty for the purpose. It provides 24/7 support system. Exposure prophylaxis or PEP for HIV infection. Exposed person preferred regime and alternate regime. So adolescent and adult more than 10 years of age and more than 30 kg. Tenofovir 300 milligram, lamivudine 300 milligram, and dolutegravir it's 50 milligram. So FDC 1 tablet OD is given. Then alternate regime is tenofovir, lamivudine, and FDC 1 tablet OD, and lopinavir or ritonavir 2 tablet BD, or tenofovir, lamivudine, or efavirenz It's given in the adults. Children more than or equal to 6 years and more than or equal to 20 kg body weight. So zidovudine plus lamivudine plus dolutegravir 50 milligram. If HB is less than 9 gram per deciliter, abacavir plus lamivudine dosage as per weight and run, and dolutegravir 50 milligram 1 tablet. Children less than 6 years or less than 20 kg, zidovudine plus lamivudine plus lopinavir or ritonavir dosage as per weight. If HB less than 9, then abacavir, lamivudine plus lopinavir and ritonavir. Healthcare worker status. Exposed person completely vaccinated antibody titer is more than or equal to 10 ml unit per ml. If source is cause or unknown for HBsAg, no further treatment required regardless HBsAg status of the source, regardless if titer falls down later. If source is negative for HBsAg. If exposed person is completely vaccinated and titer is not protective, less than or equal to 10 ml unit per ml, HB immunoglobulin 1 dose should be started immediately, maximum within 7 days. Vaccine starts 7 days vaccine. Starts second dose series 3 doses. If source is negative, is for source is positive. And if it's negative, vaccine start second dose series 3 doses. If a exposed person is not vaccinated or partially vaccinated, hepatitis B immunoglobulin dose should be started immediately, maximum within 7 days vaccination. Complete vaccine series from the series from last dose given. And then next is non-responder. If exposed person is vaccinated for 2 series and titer is not protective, HB, IG 2 doses at 1 month apart, nothing is required. Prevention of needle stick injury. Prevent the possibility of sudden patient movement during and after injection. If recapping of needle is necessary, use single-handed scoop technique. Placing sharp container at eye level and within arm's reach. Next is collect used needles at the point of use in a puncture and leak-proof container. Sealing and discarding sharps container when they are 3/4 full. Use WHO recommended safety engineered syringes. Do not forget hepatitis B vaccination and universal precautions. Be a needle smart. Do not recap, do not bend, do not reuse, do not remove, do not transport.